Thank you to the organizers for asking me to speak on the subject of the burden of microvascular complications during Ramadan. These are my disclosures. And I guess I start with the reason why probably the organizers and Mohammed had asked me to speak on this particular topic. Because if you look at the current guidelines for using the IDF-DAR risk calculator, microvascular complications don't really figure. I guess they do partly in number 9, which is renal complications, with an EGFR particularly less than 30 mils per minute, qualifying you to be into a high risk category. But the other microvascular complications, for example, neuropathy, retinopathy, are not really playing any role in terms of risk stratification. So is there evidence out there that could help us to incorporate those microvascular complications into the risk calculator? So I did a search, as I usually do with most of my talks that I do for DAR, because I think that's important, because it gives you a starting point. And when I put in the search terms, microvascular complications, Ramadan, I got 6 results. Of those, only 1 was relevant, actually, because and it was the Diabetes in Ramadan Practical Guidelines, published in 2021. But the remaining 5 papers were actually only there because one of the authors was called Ramadan, and it was something to do with microvascular. So microvascular surgery, for example, myocardial infarction. So really, it leaves you with kind of thinking, well, is there any evidence out there in terms of microvascular complications in Ramadan? Well, there are some papers have been published, and of course, Mohammed Hassan has been involved in this particular paper, basically assessing whether or not, if you've got chronic kidney disease stage 3, and people will fast even with chronic kidney disease, and this is a particular study where 63% of patients did fast, 25 patients, 19 completed the study. What did they show? Well, essentially, no major change actually in HbA1c, renal function, pre or post Ramadan. When they looked using CGM, flash glucose, there were some changes that were seen. And so if you have CKD stage 3 and you fast, then actually you do find that the peak glucose goes up, the number of hypo events doubles significantly, average duration of hypoglycemia doubles from 45 to 101 minutes, and you also record the lowest blood glucose value if you have CKD3 and you fast. So overall suggesting that it's not having a good impact in terms of glucose. And when do these hypos occur? Well, clearly they're going to occur at a time when you are not consuming calories, of course, and you're going to have the effect of therapy. So 45% of hypoglycemic episodes occurred during that particular episode. Another study, actually from Abu Dhabi, 360 patients with type 2 diabetes, CKD3, 94%, and again, 67% of people fasted. What did they show? Well, actually, reassuringly, they showed that if you did not fast, then in terms of percentage change in EGFR, really no big difference between 2 groups who did and didn't fast. And furthermore, reassuringly, a drop in the EGFR by 20%, which is considered to be clinically significant, yes or no? Well, actually, if you fasted, 11.11% got a drop in the EGFR of more than 20%. And if you didn't fast, in fact, more people got a drop in their EGFR. So suggesting so far that CKD stage 3, but that's all I found. I didn't find anything to do with retinopathy or even neuropathy. That's where Mohammed comes to the rescue, Mohammed Hassanin, where he actually provided us with a data set of collected from a large study, retrospective, and there are obviously some, well, with any retrospective data, you can see that, it depends on how you define the different complications, but nevertheless, large number of patients from the Middle East, South Asia, Southeast Asia, Africa, Caribbean, and Europe. Average age 56, type 2 diabetes duration 11 years. So if you look at that population of over 2,000 patients with type 2 diabetes, in terms of their comorbidities, in terms of microvascular complications being present, so hypertension and hyperlipidemia, 57% had hypertension, 48% hyperlipidemia. And then if you look at the microvascular complications, 31% had retinopathy. I don't know quite what to make of this, but 72% had apparent neuropathy. Quite how that was, should we say, classified needs to be clarified. And then 13.4% had microalbuminuria. So a substantial microvascular and macrovascular burden in these individuals. Now, fasting during Ramadan, again, in this population, 87% fasted. But there were a number of categories that were used to assess the impact of fasting. And this was basically whether you broke your fast due to diabetes-related illness, so about 16.8%, whether you got hypoglycemia, 21%, whether you broke your fast due to hypoglycemia, 11.1%, whether you attended hospital for hypoglycemia, small but significant percentage, 1.2%, whether you got hyperglycemia, 19.6%, whether you broke your fast due to hyperglycemia, 23%, and whether you attended hospital for hyperglycemia, 8.3%. So I would say, representative but substantial burden in people who fasted, and a lot of them did fast. So then if you break this down into people who had microalbuminuria, who didn't have microalbuminuria, and what this had as an impact on outcomes. In short, if you had microalbuminuria, then actually no difference. Whether you had microalbuminuria or you didn't have microalbuminuria, there was no difference in terms of breaking the fast due to diabetes-related illness, breaking the fast due to hypoglycemia, hospital admissions due to daytime hypoglycemia, breaking the fast due to hyperglycemia, and hospital admissions due to daytime hypoglycemia. No significant difference. What about diabetic retinopathy? Well, here, actually, again, breaking it down, there's only one significant difference. And that was breaking the fast due to hyperglycemia. And in fact, it was the opposite of what you might expect. People who had retinopathy were less likely, 16.8% broke fast due to hyperglycemia, whereas those without retinopathy, 26% broke their fast. And I really don't know how to interpret that. Maybe it's just multiple comparisons that have thrown up a p is less than 0.05, but that is the data. What about diabetic neuropathy, my favorite subject? Again, surprisingly high prevalence of this condition, but when you break them down into those with and without DPN, what you find is, again, breaking the fast due to hyperglycemia, but this time it's in the right direction, in that those people who had diabetic neuropathy were twofold greater risk of breaking their fast due to hyperglycemia, 26.4% compared to 13.5%. Other bad outcomes like breaking fast due to hypoglycemia, hospital admissions to hypoglycemia, breaking the fast due to diabetes-related illness, completely comparable, no significant difference. So if you look overall, then we did a multiple regression at the fasting days interrupted. What was driving this in this population? Well, actually, not unsurprisingly, the use of insulin. So in people who were taking insulin, whether it's Humalog, soluble insulin, human mixed-ard, you see that they had significantly greater number of days that their fasting was interrupted, particularly Humalog. I guess that reflects the fact that they're on basal bolus, 4.1 days, soluble insulin, 2 days, human mixed-ard, 1 day. Having higher systolic blood pressure also seemed to have some impact, but HbA1c didn't have an impact, and a lot of the other medications in that. Neuropathy actually did come up again, suggesting that there is some link here. So 0.96 days fasting days interrupted if you had neuropathy. Microalbuminuria, no effect. In fact, going the opposite way. Okay, so clearly a lot of work to be done. And in fact, I'm kind of just going to throw it out there that maybe fasting could have an impact on painful diabetic neuropathy. And I based this on a study that was done over 20 years ago. Sam Ayubo in Manchester showed that there's a relationship between blood glucose excursions and painful diabetic neuropathy. What did they show? Well, they took patients who had painful neuropathy, small numbers, and painless neuropathy. Pretty poor glycemic control, pretty comparable. What did they show? Well, they showed using CGM that patients who had painful neuropathy had actually got higher glucose levels, higher, should we say, glycemic excursions, 13 versus 10, and a higher M value. So in short, what they suggested is that if you had painful neuropathy, you're more likely to have shall we say, perturbations of your glucose up and down. And of course, we know that during Ramadan, what happens? Well, this is actually a study done now 7 years ago. Salam actually looked at in individuals, women who were pregnant and those who were normal glycemic compared to those who had type 2 diabetes. And what you see is that, of course, in 3 subjects who have got normal glucose tolerance, pretty flat glucose curves. But actually, subjects who have type 2 diabetes, you can see their glucose levels that are going up and down, particularly, as you can see, during iftar and during the night. So, is it possible that glucose excursions could, during Ramadan, increase painful neuropathy? Yes. And I think that's a study waiting to be done. So my conclusions are, there really are very limited studies on the impact of microvascular complications during Ramadan. And the only data that actually we have got is from this recent data set suggesting maybe an impact of neuropathy. Microalbuminuria, no impact. Retinopathy, in fact, reduced risk of breaking the fast. Neuropathy, increased risk of breaking the fast. And maybe somebody should do a study in this coming Ramadan where we ought to look at the effect of glucose variation on painful diabetic neuropathy. And it's a CGM study waiting to be done. Thank you.